Good morning, everyone, and welcome to today's webinar, LGBTQ plus Family Building. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. Additionally, we encourage you to submit questions to Dr. Resetkova using the question sections of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Now, I would like to introduce you to today's speaker. Dr. Resetkova is a reproductive endocrinologist at Boston IVF and a member of the American Society for Reproductive Medicine and the New England Fertility Society. Her research interests include the application of cost-effectiveness studies in medicine, studying the RNA profile of developing embryo, and LGBTQ plus family building. Dr. Resetkova sees a wide spectrum of fertility patients, including those who would like to explore fertility options and fertility preservation. She has a special interest in caring for those LGBTQ plus patient population. Her novel research examining transgender fertility preservation outcomes has been published in peer-reviewed journals, presented at national meetings, and received significant interest from the press. Okay, so let's get started. I'll pass it over to Dr. Resetkova.
Thank you so much, Alyssa, and thank you everybody for joining on today. So my topic today is LGBTQ plus family building, and I'm excited that you're here today. We're going to go through kind of a wide spectrum of issues relating to the LGBTQ plus population and review some treatment options as well, and hopefully have the opportunity to answer your questions related to this topic as well. So here we go. Perfect. So I have no disclosures, and here are the objectives for our talk. So today you will learn more about the various treatment options available for LGBTQ individuals and couples, view the results of one of the studies that I was involved with that Alyssa mentioned regarding transgender fertility preservation, and then also get some patient management and clinical recommendations for your patients. So I just wanted to start by giving an introduction to the LGBTQ community. Certainly the nomenclature surrounding this community has changed and evolved a lot over the years. Now one of the terms that we use encompasses the lesbian, gay, bisexual, transgender, queer, and then plus community. Oftentimes the plus refers to the intersex, the asexual community, and sometimes it's ever evolving and ever broadening group of definitions within the community. As far as best assessment tools, we think there's about 4 to 5% of the US population that identifies as a part of this community. When you use survey instruments that are online and de-identified, the proportion of individuals that identify as part of the community is typically higher than when you use in-person survey instruments. Typically, it's about 5% of women and about 4% of men that identify as part of this community. And this would be referring to sex assigned at birth in terms of the proportion. A survey out of the Williams Institute, which is a think tank out of the UCLA Law School, suggested that about 0.6% of US adults identify as transgender. And overall, internationally, this represents about 1.2 to 6.8% of adults who identify as LGBTQ+. Of course, it varies a little bit from state to from country to country, nation to nation, continent to continent, depending on the kind of the acceptability of identifying as a part of this community. So as I mentioned, the Williams Institute is a great data source out of UCLA, and this is a national map that represents the different proportions of those who identify as part of the LGBTQ+ population throughout the country. and the dark blue represents greater than 4.5% of individuals. And you can see that up in the Northeast, down in the Southeast, and also West Coast is a largely represented population. So being in our area here in New England, we do get a lot of patients who identify as part of this community. And so it's important to develop programs that are accepting and inclusive, where these patients can feel comfortable getting care. So Boston IVF, about 5 to 10% of our patients identify as part of this community. We have improved our data capture over time, and so now we know that it's over 5% of our patients. Potentially could be more. Some patients elect not to fill out this type of identifying information, so we know it's at least 5% of our patients. And we treat all members of the LGBTQ plus community, and in fact we have been doing so since our inception of the clinic over 30 years ago. So this is a very vibrant part of our care, and we're very proud to offer treatment options for the LGBT community. Some of the needs of the community, and there really are some very specific needs that are important. Certainly they want to be respected, and they want their individual status and then also relationship status to be respected and recognized. There's some pronouns that are typically used in the LGBTQ community, so an understanding of those pronouns and the terminology and the way that patients introduce themselves is very important. Certainly the availability of procedures tailored to the LGBTQ community is important. And they really want to partner in the process of family building. So somebody who can carefully review all available options and ultimately partner with them, not only reviewing in detail the types of medical treatment, their potential effects, but also timelines, costs of different types of treatments. That's very important in order to help assemble the best plan for our patients. And we won't be talking about it too much, but it is important to recognize that adoption and fostering are also options that are available for the LGBTQ plus community. They're not treatment options that we offer through our center specifically, but if patients are interested, we're always happy to talk about that as an option in family building, although it's not something that we offer through our center. And lastly, I put kind of thinking outside of the box. Sometimes we have to be a little bit creative when it comes to either single patients or partnered patients that come in with certain reproductive organs. We have to think a little bit outside of the box in terms of optimizing their future pathways to fertility. And so that can be a very nuanced discussion and ultimately a very, very interesting one when it comes to optimizing the course for different patients. So I thought I'd start off also by identifying some very important terms when it comes to caring for the LGBTQ plus community. And I found this to be really important when I was starting my work and kind of expanding access for this population. So firstly, we'll start with sex, and this is particularly the assigned sex at birth. So this would be either male, assigned male at birth, assigned female at birth, or potentially a medically intersex condition where there are both XX and XY cells present. So that's very basic, the sex that is assigned at birth. Now, gender identity is how one feels and sees themselves. So do they identify as a woman, as a man, or do they identify as non-binary? So neither. And typically somebody who is non-binary would go by gender neutral pronouns like they or them. Then of course there's gender expression. So how one expresses themselves. Do they express themselves as feminine outwardly or outwardly express themselves as masculine? And this, of course, affects potentially choice of dress, behaviors and mannerisms, how one outwardly expresses their gender. And of course, you could be kind of neutral or androgynous, just somewhere down the middle. And then ultimately, there's also sexual orientation. So who are you attracted to? Are you attracted to men, women, or are you attracted to somebody who assumes more of a non-binary role? So I think this is really important in framing some of the issues that are really important to the LGBTQ plus community. Today we'll be talking about lots of treatment options. We'll be talking about fertility treatment, fertility preservation, and we'll focus on lesbian patients, gay patients, transgender patients, and a little bit as well on non-binary patients. It's worth mentioning that intersex patients can be very medically complex based on different kinds of endocrinopathies or potentially limited treatment options just based on the available gonads. So we won't be going into that discussion because that's a little bit too detailed for the scope of our lecture today. So let's go ahead and jump in. So one of the data sources that I found when I was preparing for this presentation was just from 2015, published by Taryn et al. In Reproductive Biology and Endocrinology, really noting that there's a paucity of data looking at lesbian and gay treatment outcomes in fertility clinics. So despite the fact that in many of the countries that are producing leading publications in the fertility landscape, there's just really limited data that was available, at least as of 2015. And so this particular paper was called Deficiencies in Reporting Results in Lesbian and Gay Patients After Donor Insemination and ART. At this time, there were really only sort of 3 good studies looking at outcomes for lesbian patients and 1 good study looking at reproductive outcomes for male-male couples. Now, fortunately, those publications have grown over the years, but I will share with you some of the sort of good foundational studies that are present and then go into some of that data so you can be a little bit aware of what the reproductive outcomes and success look like for your patients. So we'll start off by talking about lesbian couples. So of course, lesbian couples can choose to present, as a pair, or ultimately, sometimes we have single patients who are same-sex oriented as well. And it's important to note that when a lesbian patient presents, there are multiple different treatment pathways that they could take. Some choose to start their treatment journey at home or potentially working with a midwife, just using intracervical insemination, which would mean that they would either purchase donor sperm or get sperm from one of their friends or a sperm donor that they want to work with and do the process themselves at home or with a midwife. Now, we don't offer that type of treatment because donor insemination with intrauterine insemination is a more effective treatment strategy. And as medically supervised treatments, we want to offer the best success rate to our patients. So I'll be talking specifically about therapeutic donor insemination, or TDI, understanding that some patients will elect to go a more home-based route, typically to save money on the costs associated with treatment. So for lesbian couples, we generally recommend about 6 cycles of treatment with donor insemination for those who are under 35 years of age, really to optimize their treatment success. And then many Massachusetts insurance, many New England-based insurances will sort of require 6 rounds of insemination in order to assign an infertility diagnosis to a patient if she's naive to sperm, if she's never had intercourse or prior insemination with donor sperm. So we'll typically do about 6 rounds of treatment. And if she's older, greater than 35 years of age, then we'll generally recommend somewhere between 3 to 6 cycles of treatment with insemination. The process of insemination is very simple. It requires that the patient tracks their cycles. So typically tracking with home ovulation prediction kits, or we can do the tracking at our center, and typically the success rates are a little bit higher when that's done. And essentially we perform the donor insemination when the anticipated ovulation event is occurring. So that's typically the day after she's identified a positive ovulation sign at home with home-based monitoring, or 36 hours after a medication trigger is administered to release an egg. This can be performed in the setting of medicated cycles or unmedicated cycles. And most of our patients start treatment using unmedicated approaches. So we're just tracking their natural cycle, unless they have a history of polycystic ovarian syndrome or some other condition that would require the induction of ovulation or potentially assisting multiple eggs to be released at the same time. Most of the data shows that medicated approaches are beneficial because, the unmedicated approaches are beneficial because when you add in medication like clomiphene citrate or an aromatase inhibitor like letrozole, typically what you're doing is increasing the number of eggs that are being released. So maybe 2 or 3 instead of 1 that typically is released in the natural cycle. The success rates are about the same amongst both strategies, but the twin risk is much higher when you're inducing ovulation of additional eggs. So typically we want to optimize the success rate of one singleton baby. And so typically we offer an unmedicated approach right out of the gate. So there's a great landmark study on donor insemination published in Human Reproduction in 2000. This was comparing insemination success rates in single women and lesbian couples and looking at pregnancy rates. This is a great study to kind of give an overall prognosis of the success rate, how many cycles it typically takes to conceive. So this study, there were 675 cycles in single women and lesbians combined. You can see that there's about 139 cycles in lesbian patients and 536 in single women, and the outcomes were compared. So notably, the lesbian patients were a little bit younger when they initiated treatment, with a mean age of 34 years, as compared to the single women who are typically a little bit older, about 38 years. Clinical pregnancy rate was significantly higher in lesbian women at 57%. And then the cumulative pregnancy rate after 6 cycles of treatment, which as I mentioned is kind of a typical pathway or typical initiation pathway, was 70% for women in same-sex relationships as compared to 47% for single women. So why the differences? Well, ultimately age is a factor. Pregnancy rate decreases with increasing age. And the authors also postulated that there was a higher incidence of potential prior infertility in some of the single women, and that could contribute to a lower success rate overall. Interestingly, in this group, the miscarriage rate was also higher in single women than in lesbians, and that was actually still seen when there was a control for age. So some of the notes on donor insemination, it's really important to know, what your patient experience will be if you refer her or them for treatment. Ultimately, donor insemination is very, very well tolerated. So there's very minimal discomfort with the process of actually doing the insemination. And if patient does have a lot of discomfort, or she's had a history of violence or has a lot of difficulty tolerating an examination, we are able to offer in some cases for this procedure to be done under anesthesia to make it more comfortable. Other approaches that can be used for patients who have a lot of difficulty tolerating this type of examination is to use an anxiolytic like Xanax or Valium before the procedure. That's something that we don't do routinely, but we certainly can offer it for patients, and it's been noted to make the procedure a lot more comfortable as well for some. Just a couple of facts so that you understand some of the costs that are associated with treatment. There's many sperm banks throughout the country, over 100 sperm banks. Some of the leading sperm banks that you may have heard about are California Cryobank, Seattle Sperm Bank, Fairfax Cryobank. They're some of the larger ones that have a large number of donors, but certainly there's a lot of smaller sperm banks that have sort of boutique sperm options, such as limiting the number of potential children per donor, and then limiting geography as well. So there's lots of different options that are available to patients depending on what they're looking for. But the average cost of a vial of sperm is about $750, so it's not cheap. The average cost of insemination at our center is about $450. And then the patient can also opt for paying for monitoring, including blood work and ultrasound, and some other medications to optimize the treatment. For some patients, they do have coverage for this. So some of our New England-based insurers do have fairly good treatment coverage for insemination. And a lot of the newer insurances are really focusing on expanding access to the LGBTQ population. And so they are offering treatment coverage even without a diagnosis of infertility. So that's been great for our patients who have benefited from that. Most insurances, I did mention, don't cover the costs unless there is an infertility diagnosis, but we're seeing some of that change. Patients will often ask, what's easier? You know, I have somebody in mind who I would consider to be my sperm donor. It is always a little bit cheaper, typically and a little bit faster to choose one that is anonymous, because they don't have to go through the quarantine period, which is about 3 to 6 months, depending on what sperm bank they go through, where the sperm has to be quarantined while serial STD testing is being completed. So if time is an issue, we do recommend for anonymous sperm donation in many cases. So there's a lot of question as to should I do 1 insemination per cycle or 2 inseminations per cycle? And really the best study that looked at this was just published in 2019 in the Journal of Assisted Reproductive. And they looked at over 20,000 cycles over a 17-year period, so really expansive. And about 7% of the patients were lesbian couples of the total number. And the success rate, while it's better per cycle of doing 2 inseminations, 17%, over 15% per cycle from just doing 1, it typically is not thought to be cost effective and is insignificantly better in terms of the success rate. So ultimately, we typically recommend doing 1 insemination simply because the cost of sperm is so high. But if a couple or a patient wants to really optimize their success rate per cycle, it is reasonable to consider doing 2 inseminations, but the costs do increase significantly. They really at least double because monitoring does need to be included to optimize the success rate. So of course, IVF can also be done for lesbian couples, either right out of the gate as an initial treatment option, or it can be done as a secondary treatment if insemination is not successful. There's a study that came out looking at IVF specifically for lesbians in comparison to heterosexual couples. And this was published in 2014 in Human Reproduction. Interestingly, they found that the success rate of fresh IVF, meaning that an embryo is created and transferred within the course of the same month in the same cycle, success rate was a little bit lower for lesbian patients than it was for heterosexual couples on a per cycle basis. And the playing field was somewhat evened out when it came to a frozen thawed embryo transfer. Success rates were similar. They didn't have a clear reason for this, so we're not really sure why that exists. But the overall pregnancy success rates were quite similar between lesbian couples and heterosexual couples at over 60% over 2 cycles. In preparation for this talk, we've examined some of our data, looking at our same-sex female couples, and we've noted that the success rates over an average of 2 cycles are actually in excess of 80%. So I'm happy to report that, and we'll be looking at getting that out there into the literature soon as well, as it's needed. There is one more technology that's pretty phenomenal that I want to talk with you about as well. And this technology is called partner-assisted reproduction. You may have heard about it called reciprocal IVF, or potentially co-IVF, or even shared motherhood IVF. So it's got lots of potential different titles depending on what clinic is referring to it. Essentially, it's a process where so 2 people who have assigned female sex at birth are undergoing the shared process of IVF treatment. In that, one partner will undergo ovarian stimulation for egg retrieval, the first part of the IVF, and then the second partner will undergo preparation of the uterine lining for embryo transfer. So all of this can sort of be magically coordinated into one cycle. So the cycles can be aligned in order to allow this to happen at the same time, or it can be done over the span of 1 or 2 months, especially for couples who are interested in having chromosomal testing of embryos. That would typically necessitate it to be done over a 1 to 2 month period. However, it allows for a tremendous involvement of both partners and for both partners to really feel like they've had an integral process in family building. So it's really been an amazing and very popular treatment option. And we've noticed that over the years, it's definitely become more popular. In fact, in 2019, we saw almost a 50% rise in the number of patients who went through this type of treatment at our facility. So expecting kind of the growth through 2020 and beyond. It is typically more expensive than insemination. However, the success rates are excellent. So in some cases, I would postulate that it's actually more cost effective than insemination, especially depending on what the different coverage options are for the couple. In rare cases, that is also covered by insurance. So one of the best little captions of this I found on the internet was this very simple diagram where the genetic mother and essentially the woman who undergoes the ovarian stimulation egg retrieval just needs to have a decent or good egg reserve, good number of eggs growing on her ovary, some genetic testing to determine that she is not a carrier for the same conditions that the donor is a carrier for. And ultimately, the birth mother or the one who will carry the pregnancy should have a normal uterine cavity, one that can receive an embryo, and is ultimately deemed to be healthy for pregnancy. So, and if she has any underlying medical conditions, that they're essentially optimized before the embryo is transferred. So very simple diagram for what can be a very complex process, but an incredible one. Success rates for this treatment. Best study looking at this was published in 2017 in Reproductive Biomedicine Online. This is out of a UK-based clinic where they had 6 cycles from 2011 to 2016. I'm sorry, 172 cycles over 6 years in that time frame. And they noted that the majority of those cycles were done synchronously, which means that the embryo, the IVF portion, the egg retrieval, and the embryo transfer were coordinated. So the embryo was transferred fresh instead of being frozen and thawed out. And the majority of these patients did undergo single embryo transfer. And in the study, they noted that the single embryo transfer rate went up over the course of the years that they were doing the study. And ultimately, the success rates for transfer also increased over their time span, reflecting some improvement in the laboratory. The overall cumulative live birth rate from the cycle was 60%, and 14% of patients had twins. And that twin rate really decreased over time as they started to favor the single embryo transfer. So you can see the success rates are quite good when it comes to this type of treatment, which is why it may be cost effective for some patients. Notably, because this was a UK-based study, they did also make the mention that about 10% of their patients were using cross-border care, because in a lot of European nations, this type of treatment is not legal, it's not offered. So about 10% of the patients were actually coming cross-border from different European countries seeking treatment at their clinic. And that's really still the case. So there tends to be a fair amount of cross-border, cross-nation tourism for this type of treatment. So of course, I just wanted to mention that donor oocytes, donor egg treatment, and gestational surrogacy are also available for lesbian couples or single patients. However, we won't go into those details in today's talk. So what about gay couples? So we're talking about male-male couples. These are couples who typically have sperm, typically excellent quality sperm, depending on the age that they're starting treatment. They do need typically egg donation and gestational carriers. These can either be women who are known to them or anonymous. And if they are working with an anonymous or somebody who they have not met before, there's typically an agency that kind of helps them recruit that person and creates the agreement, puts the agreement in place, and then has a legal framework for making sure that it's a safe process for both the donor, the surrogate, and then also ultimately the couple and the intended parents. We do involve, for all these complex treatment pathways, we do involve our social work team as well. And in regard to the egg donation can be a fresh egg donation, meaning that the egg donor will be cycling on behalf of the intended parents, or it can be a frozen egg donation from an egg bank. We have many established relationships with egg banks throughout the country, and ultimately the frozen donor egg banks have already the egg lots are already available, they already exist. There's a little bit more security because the couple is able to select an egg lot and have a really good understanding of the quality of that egg lot even before they select it. There's a little bit more variability in fresh egg donor cycles. Typically, in our experience for the gay male couples, both men often wish to be biological parents. So they may choose a portion of the egg lot that they may want to inseminate with their sperm. And typically, they're choosing to inseminate a portion of the eggs with each of their sperm. That's typically what we see. When it comes to surrogacy, there's two different kinds of surrogacy. There's traditional surrogacy, where the surrogate who is carrying the pregnancy is also essentially her eggs and her uterus are part of the integral part of the process. It's really not favored. It's not illegal everywhere in the country, but most states do not have any protections surrounding traditional surrogacy, nor protections for the intended parents. So it's not a favored approach, though a small proportion of surrogacy in our country is still traditional surrogacy. And overseas, there may be a little bit more traditional surrogacy depending on which nation we're discussing. So more what we're talking about through our clinic, the only type of surrogacy that we offer through Boston IVF is gestational surrogacy. And that means that egg donation typically and autologous sperm is being used. And then ultimately a surrogate will carry the pregnancy derived from a donated egg and autologous sperm from one of the members of the couple. Surrogacy laws vary widely by state, so it's really important to have a very, very good reproductive attorney working with couples, either gay couples or heterosexual couples or single patients who are working with a gestational surrogate. As you see here, there's a wide spectrum of colors represented on this map. The dark green states are the states that have really, really solid protections in place for both surrogates and intended parents. And the light green, which is the majority of the country, have some protections and some law in place for surrogacy, but may require some finer points, like the parents may have to do some paperwork post-birth in order to formally identify themselves as the parents of the child. And then the red states are really a no-go. And you'll see here that actually, I'm sorry, this is overshadowing New York. New York State previously had no protections, but there's some changes that are happening up ahead in 2021. And so we're going to start to see some changes in New York State, and potentially some surrogacy will come back to that state as well. Success rates for surrogacy treatment are generally very, very high. For gay male couples, there's typically excellent quality of sperm, and the egg donors typically are somewhere in their 20s or their very early 30s. And so the success rates for each embryo to take an implant are typically very good. Surrogates have, in almost all cases, carried a pregnancy to term previously, so we know that their likelihood of implanting an embryo is also very high. So we're talking about excellent success rates. You know, unfortunately, the treatment is costly because all that reproductive case management, essentially with the lawyer and the teams that are in place in the agencies, that is costly. And then the surrogates are typically compensated as well. We strongly advocate for single embryo transfer. And I will say a lot of surrogates have a lot of reservations about transferring back 2 embryos. So it is really much more the fashion to transfer back 1 embryo at a time, and for gay couples to build their family one baby at a time, and ultimately potentially have a future pregnancy a couple of years down the line if the other partner would like to also have a genetically related child. Interesting study looking at the psychological well-being of different types of couples. This is looking at gay father families, lesbian mother families, and heterosexual parent families, a study out of the Netherlands in 2018. And interestingly, they were studying whether there were any differences in parental stress, depression, or relationship satisfaction. And they found that amongst these couples, there really wasn't. So they all experience the joys and the stressors of parenthood in the same way, and ultimately make really excellent families. So I also want to spend some time talking about our transgender population, and this is really growing, a growing segment of our care here at Boston IVF. Firstly, we'll talk about assigned male at birth and then assigned female at birth patients as well. So for those who are assigned male at birth, the treatment options are surrounding either sperm cryopreservation, so essentially fertility preservation, or obtaining sperm for a current pregnancy attempt. And if the patient is comfortable obtaining sperm through ejaculation, then she or they can do so if they're able to. Surgical retrieval can also be used. That would be typically done with a male reproductive specialist or a reproductive urologist if surgery is needed. And typically the patient will need to come off gender-affirming hormones. So now we're talking about testosterone blockers or estrogens. And typically the period of time that they would need to come off treatment is about 3 months in order to have a decent sperm sample. It's typically what's advocated. There's some data that's coming out that sperm quality may be affected in those who are transitioning, assigned male at birth, now living in a female role, probably due to prolonged estrogen administration and sometimes due to other behaviors like tucking of the gonads, which can result in increased heat exposure and potential damage to sperm production. So for most studies, we see that the sperm production is compromised by about 30%. So it is notable between cisgender and transgender patients. However, most patients in all these studies are still able to produce sperm that's at least viable for IVF treatment. So in counts that would be viable for IVF treatment, and oftentimes viable for intercourse if that's something that they can do or feel comfortable doing, or insemination if they have a female partner. Ultimately, for artificial reproductive technology, or if they have a male partner, surrogacy with egg donation is also an excellent option. For those who are assigned female at birth, so now transgender male or trans men, oocytes are available either through fertility preservation from previously or current fertility preservation strategies, or potentially they can actually cryopreserve ovarian tissue as well. Ovarian tissue is not something that we offer through our center, though there are some regional centers that do offer that technique, typically used in a very limited capacity for very young patients who have not gone through the pubertal transition yet and want to explore options of fertility preservation. So that's a very limited case use, but it is a technology that's available. Most patients will choose to undergo egg freezing or oocyte cryopreservation to preserve their fertility, and that can be safely done once they've gone through the pubertal transition or having menses. If they're assigned female at birth, trans men may choose to carry a pregnancy themselves. This is a picture here of a very famous case of that. This is Thomas Beatty, who, as a trans man, who carried 2 pregnancies, and ultimately was very popular on the cover of People magazine and other magazines for being the first trans man who had undergone gender-affirming surgery with a double mastectomy and had carried ultimately 2 pregnancies. And unfortunately, he split up from his cisgender female partner, but I did read that he has since had another child, actually, but his partner, female partner, carried the pregnancy. So ultimately, he is the father of 4 children. And of course, a partner or surrogate can also carry the pregnancy if the trans man is not comfortable carrying, and that's typically the case. So typically, a female partner or surrogate can carry the pregnancy derived from his eggs. Some of the specifics in working with the trans community are really to create an open and inclusive environment. We do have the option of not inducing a menses prior to treatment. There are some sort of tricks that can be used in order to optimize the likelihood of not needing to induce menses before doing any egg freezing treatment. Vaginal atrophy is something you have to be aware of for patients who have been on testosterone for a long period of time. Sometimes a little bit of estrogen cream can be used to soften the vaginal mucosa and optimize the experience with any sort of vaginal procedures. And oftentimes we'll actually avoid vaginal procedures altogether and just use transabdominal ultrasound for monitoring. And ultimately it comes down to setting realistic expectations and having good rapport with a medical provider who's trained and used to working with the trans community in order to make the experience for trans men easier. So we talked a little bit about the incidence of transgender in the United States. One of the things that we're noticing is a trend for diagnosis and treatment at a younger age, so a lot more adolescents are transitioning. And then many transgender men or trans youth have an interest in future family building. So one study is actually out of Belgium in 2011. I see that we're getting a little short on time, so I'll just kind of hit the high points. About 38% of patients who had already undergone a gender-affirming surgery ultimately report that they would have considered freezing their eggs had there been an option. So these are patients for whom this really didn't represent a good option because the technology just wasn't there. But they do have that sort of retrospective desire to have frozen oocytes if they had that option. So we're ultimately seeing that a lot of patients wish that they had done so, and more patients are being referred for consideration as well. Another study looking at 32 trans patients, more transgender males here represented than transgender females. And 47% wanted to ideally build their family in a way that would allow them to have biologically related offspring. And many identified that their transgender status could be a barrier to becoming a parent via their ideal method. So definitely the transgender population is definitely thinking about this. And so it's important to consider referral to a fertility clinic, specifically before doing anything that would be gender affirming. So we have a landmark study that was published through our center from our experience working with transgender male fertility preservation and family building. And so I'm happy to report and present on this study to you. So this was a study that we did over an 8-year period, and the inclusion criteria was all transgender men who completed an egg stimulation, oocyte stimulation cycle, either for the intent to preserve eggs or oocytes, preserve embryos, or actually transfer back an embryo into their own uterus or ultimately a partner's uterus. So overall, we had 53 patients in that time frame who presented for consultation to discuss treatment options, and about half of those underwent treatment. It's pretty consistent with what we see published in the literature as well. So you can see the ages were wide spanning, ages 14 through 39, average was about age 27. And then the majority of patients just needed to undergo one cycle because these patients do very, very well, as you'll learn. And so ultimately, most patients just have one cycle of treatment in order to either freeze their intended number of oocytes, embryos, or ultimately have a good prognosis with pregnancy success. Most cycles were for egg freezing. Some cycles were for IVF with embryo freezing and some for embryo transfer. Most patients have been on testosterone for a number of years who presented about 3 to 4 years. And on average for our patients, they had been off testosterone for about 3 to 4 months before commencing any sort of treatment. So our results. So as you see here, the ages of all patients on average was about 28. The patients who were coming in for egg freezing ultimately were a little bit younger. They were about 25. Whereas the patients who were coming in with the desire to build a family with an intended embryo transfer, about 32. And the number of eggs that were harvested on average was 19. And it is worth mentioning that at our center, an average fertility patient egg yield is about 8 to 12. So the response rate for this patient population was really tremendous. We then did a matching study looking at our cisgender patients versus our transgender patients to have an understanding of what the similarities and differences were. And we identified that compared to our cisgender patients, so typically heterosexual couples having treatment, the number of eggs that were harvested in our transgender patients was actually higher, 18 versus 14. So these were matched for age and egg reserve and BMI. So ideally identifying a patient population that was as similar as possible. What's worth mentioning is our transgender patients, because we were really trying to optimize our success rate over the course of one cycle, they were typically administered a higher dose of hormones to achieve that effect. So the expense of the hormone treatments may have been a little bit higher in order to get this excellent yield of oocytes. So this study was really very well received, got a lot of press, and it also offered a descriptive approach for providers who may not be as comfortable treating transgender patients. And we hope that that's allowed more patients across the country to gain access to fertility treatments through just provider comfort with this technology. Unfortunately, the limitations is still a relatively small number of patients, though it's growing. Even since we published the study, we've had about an additional 15 patients come through the center. So at least a 50% growth year over year over the last couple of years. And then ultimately, you know, it's really, I think, going to be something that we keep up with and keep putting out there so that people can have a better understanding of how this patient population responds to treatment. So the study, additional studies have come out since we published this at the beginning of 2019. Some studies out of UCSF, Brigham and Women's, also NYU, that have been supportive of our data. And there's even been some case reports of trans men who have undergone egg freezing, either for the purpose of fertility preservation, or even some who have undergone IVF treatment without coming off testosterone. So it remains to be seen whether that's a reliable treatment and whether patients even need to come off testosterone treatment at all and lose some of the gender affirming effects. A quick note on non-binary individuals, we certainly treat them. They may or may not experience infertility, just like their cisgender counterparts. And the success rates will be expected to be similar to those who are cisgender. So certainly a growing part of our patient population as well. And just a note on non-binary individuals, you know, the terminology can be really specific and really vary from individual to individual. So typically we're using more gender neutral pronouns like they or them for these individuals. And it's important to ask your patient, you know, what they really prefer to be called and use first names when possible. So just a little bit of logistics so that you understand what happens when a patient comes to our center, when you refer somebody to our center for treatment. Firstly, they'll speak to a centralized booking center. This is Rhonda. She's one of our staff who's been with us for over 30 years. So a lot of you or your patients may have spoken with Rhonda before. She's wonderful. So, you know, our staff is well trained and really comfortable working with patients who identify as LGBTQ using very sensitive nomenclature. So you can rest assured that they would feel comfortable booking an appointment. They're scheduled for a 1-hour consultation to meet with one of our physicians, myself or one of my colleagues. And then typically we recommend some baseline testing, some ultrasound and blood work for patients. And we do have special accommodations if they're not comfortable having transvaginal scans. So we can do a lot of things to more comfortably assess patients, like transabdominal ultrasound and less frequent monitoring. And then of course we have a complete social work team and a psychologist as well at our Domar Center. So in case patients need a little bit more of that, that's actually offered in-house as well through our center. So they don't need to go outside. We kind of keep that all in one place. Some treatment timelines important for consideration. For those who are assigned female at birth, testing typically takes a month to figure out if they're good candidates for fertility treatment. Typically, if they're working through insurance, it's about 1 month for insurance approval. And then the treatment course can be as little as 1 month. So it's relatively quick. If individuals or couples are working with a gestational surrogate, typically that process can take a while to get matched with the surrogate. So it can take up to 6 or 9 months. So I always recommend that patients get seen probably about 6 to 12 months before their initial goal start date in order to start the process, meet with a reproductive attorney, get matched with an egg donor or gestational surrogate if applicable, and just so that that process isn't rushed. And there has been some impact from COVID on some of these timelines, so especially now it's important to present earlier than later. And lastly, I wanted to close just with a note on how to establish an LGBTQ plus friendly practice. Signage is important. So if you are looking to become more inclusive, having something simple like some pride flags either throughout your office or on your web page is really important. People feel very welcome. Also having some photography of not just heterosexual couples will create a more inclusive practice setting. Neutrally greeting patients by their name and referring to partner as opposed to wife or husband is also helpful, and there can be a lot of staff training to help optimize that experience for patients. Having gender neutral or all gender restrooms to make everybody feel more comfortable. And then having some unifying paperwork and documentation that's a little bit more gender neutral. So looking at your intake forms for your center can be really helpful in making patients feel more comfortable. And ultimately, staff training. This is something that's ongoing for ourselves, our physician staff, our patient-facing staff, and even people who work in billing and receptions. Really, really critical to have good training because, again, this is such a growing segment of our worlds and of our practices. So some really, really good resources to use are Fenway Health and the Family Equality Council, which has actually created a module called Open Door, which can help train up your staff and your workforce, whether they be clinical or administrative, to better work with and integrate our LGBTQ patient population. So I hope that we have addressed the objectives today. I've really enjoyed speaking with you, and ultimately, feel free to ask any questions. I think we still have about 10 minutes, so it should be a good opportunity to have a few of your questions answered if you have any. And Alyssa will also be giving my contact information. So if you have any more sensitive or patient-specific information that you want to reach out to me about, very happy to answer some of those questions for you. So thank you for your attention, and I'll send it back to Alyssa, who will be able to let me know if there's any questions that have been asked throughout this talk.
Thank you, Dr. Resetkova. So we're now going to begin answering some questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. So the first question is, can LGBTQ plus patients go to any Boston IVF location?
Great question. So yes, LGBTQ plus patients can be seen at any one of our locations, whether that's New England, New York, or even some of our further locations like Indiana. We do have treatment options that are available at all centers. Personally, I work out of 2 centers at Boston IVF, working at our South Shore Center in Quincy, and I also see patients out of our North Chelmsford office as well, just a little bit north of Boston. And I'm very happy to see your patients, and I do have a special interest in treating this population.
Thank you. And then just can you go expand on currently how we're seeing patients through telemedicine, maybe give some information on that?
Yes, it's a changing world with coronavirus, so we're doing a lot of telemedicine. All of our initial consultations are scheduled through Zoom or phone if the patient should prefer that. Most patients are preferring Zoom. So they're video teleconference, and ultimately patients have been really taking to that. And it has taken geography is a little bit less of an issue now because we have a lot of different monitoring sites, so patients are able to access our services a little bit easier, and I would say probably a little bit easier for patients to get in to be seen sooner as well.
Okay, great. And I have one more question. Do you know of any organizations that give funding or help LGBTQ plus patients with family building?
Great question. So there are some organizations that specifically address this need. In particular, one of the ones to be aware of for male couples or gay male couples is Men Having Babies. It's a wonderful organization that holds annual conferences in different areas of the United States and also in the world. And they do have some discount programs that are available for men who go through their sort of member clinics. So that's a great organization. As far as for female and trans patients, ultimately there's some fertility grants that are available through different type of programs. I would recommend kind of an internet search because they're always changing in terms of what's available and who is offering a grant and when the application dates are. But there's a lot of fertility organizations that will often kind of raffle off or give out a cycle of fertility treatment, or there's grant programs that will offer a set amount towards treatment. So whether that treatment involves egg freezing, whether that treatment involves IVF or even surrogacy or egg donation, that amount is typically available for the patient or couple to apply. So an internet search will go far, and then our teams are really good about identifying any grant programs that are available. And similarly, it's important to note that fertility treatment for patients who are at need, we do offer some discount programs through our center as well. So it may make the cost of fertility treatment more accessible than they initially think if they are eligible for some of the discount programs.
Great, thank you. And thank you for everyone who attended today's webinar on LGBTQ plus family building. If you have any other questions, please contact me, Alyssa Cooper at ecooper@bostonivf.com or 978-302-2958, or Nina directly at the email provided on the screen. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you would complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF and Dr. Resetkova, we say thank you for joining us today and have a great rest of your day. Thank you.
Bye, everyone.
Bye.